welcome to All In Conversations on Health in Nashville. I'm Molly Sutter, Interim Executive Director of Nashville Health. At Nashville Health, we are committed to working collaboratively with partners across the city to address critical public health issues. Today, we are pleased to partner with the Metro Public Health Department to host this important conversation on vaccine distribution and acceptance. Before I introduce our moderator for today's conversation, I want to thank our presenting sponsor, Blue Cross Blue Shield of Tennessee. They have been wonderful supporters of Nashville Health, and we are grateful for their continued partnership. Lastly, we will be taking questions from the audience today, so please use the chat function to submit your questions at the bottom of your screen. Now, it is my honor to introduce our moderator, Nashville Health founder and chairman, former U.S. Senate Majority Leader, Bill Frist.
Thanks, Molly, and thanks both to Nashville Health and the Metro Public Health Department for hosting today's discussion. In less than a year since COVID-19 began to rage across our country, leading scientific minds and amazing government and private partnerships have brought us these life-saving vaccines to reverse the pandemic. We've all watched the news intently about vaccine distribution, wondering how we and our loved ones will gain access to the vaccines. And we've also wondered how the most vulnerable in our population will be able to get that vaccine. Our guests today have been on the front lines fighting the pandemic and now making sure that vaccines are rolled out across Tennessee and here in Nashville in an equitable way. We have with us today Dr. Lisa Piercy, Commissioner of the Tennessee Department of Health. She's held this role since January 2019. And we have Dr. Alex Jahanger. Dr. Jahanger is a professor of orthopedic surgery at Vanderbilt University Medical Center and chairs the Metro Board of Health here in Middle Tennessee and the Nashville COVID-19 Task Force. Well, let's jump right in. And I'd like to start by asking each of you to give a brief overview of your respective organizations, and then at a higher level, because we'll come back and go in more detail in just a bit, your role in fighting COVID-19, as well as the vaccine distribution. Commissioner Piercy, why don't you begin, and then Alex, jump in after that.
Thank you. Happy to. Thank you for having me, Senator Frist. And hello, Nashville Health, and good afternoon. I'm Lisa Piercy. I'm the Commissioner of the Tennessee Department of Health. And as Senator Frist mentioned, I've been in this role right at 2 years now. And the question I'm frequently asked is, did you sign up for all of this? And while I jokingly say no, actually, this is just core mission to the Tennessee Department of Health. Our pandemic response is something that we have prepared for years. We've never seen one on this scale before, so we don't have a playbook, and we've had to learn as we go. And it's been an iterative process, but something that not only this department has taken in stride, and all of that credit goes to the 4,300 employees that we have on the front lines, but also it's given us an opportunity to coordinate with the governor's office in the unified command structure and really bring the Department of Military and TEMA, as well as the Department of Health for a coordinated response. So I think many of our successes can be credited to that collaborative approach. And so I'm glad to be with you today and tell you a little bit more about that.
Thank you, Commissioner. Dr. Jahanger.
Thank you, and thank you for having me. I'm Alex Jahanger, and as Dr. Piercy noted, I get asked the same question: is this something that we signed up for? And I think as chair of the Metro Board of Health, I have a great honor of being able to oversee an organization that prior to the pandemic, about 700 employees that took care of the public health of our city, from everything from what you normally would think about with infectious diseases that have in our city, all the way to animal control and vehicle emissions. And so for us now, over the past year now, we've really obviously had to keep those functions going, as well as focus our efforts on this pandemic in our city. In October, when the pandemic first hit the city, I was asked by the mayor to help lead this task force. And this task force really focuses on the local national response, and it involves people from all parts of our city to really look at not just the disease response in the testing and now the vaccine rollout, but also look at the policies and the economic sides of things. And so it's been a really great opportunity to, and again, we're glad to brag about how our city has done and ways we can make better. So again, thank you for the opportunity to be here.
Good. Thank you both. And, one of the real privileges, opportunities we have today is the fact that we have the state government represented and then the local government. And we know so much of what's going on is a partnership between the local level, the regional level, the state level. And to have both of you to have a dialogue today is, to me, just a fantastic opportunity for better understanding for us all. Commissioner Piercy, why don't we just start right in? How is the rollout going in Tennessee? Every evening when I'm home and I turn on the news and I see all this chaos around the country in terms of people getting vaccines in their arm, and you hear all the bad stories, and you see how painfully slow it's going as everybody is anxiously waiting. How do you characterize the rollout going in Tennessee so far?
Yeah, I'm glad you asked that question because I think a lot of people, this topic and many other topics, they hear the national news and they assume the same thing is going on in Tennessee. And that is simply not the case here in our state. We had sort of a jump start on pandemic vaccination efforts because for the last 4 years, we've been practicing this through our Fight Flu TN events. And when I've mentioned that to some of our federal partners, including Vice President Pence, he said, I've never heard of anybody doing that before. So that was a good thing. That gave us a leg up and helped us to sort of roll right into this. Now, what did we learn? Very quickly, we learned that you can't do this just like the flu shot because there are priority phases and there is a scarce supply. So you can't have thousands of people showing up at one site because people are going to be very frustrated when the inventory runs out. But from the infrastructure and the relationship standpoint, we had a bit of a head start. And so what you probably remember seeing is that very early out of the gate, we were very quickly in the top 10 and at one time got as high as number 3 in how quickly we got out our first doses. What you have seen now is that we're starting to fall in the rankings of first doses, but we're right there near the top in second doses. And that's because everybody who got an early first dose now has to get a second dose. And by default, that slows down first doses a little bit. That's all going to equal out and net out in the next couple of weeks. But that has gone really well. The one thing that we continue to struggle with, really the only thing we continue to struggle with, is supply and supply to sites. Another success factor that we had is, many states just had the vaccine sent to a few select locations, 3 or 5 or maybe 10 or 15. We actually started with 128 sites to begin with. And, when you're learning as you go, when you look back, the states that sent it to more sites initially have done better. There's been a lot of positive press for West Virginia, and West Virginia did that at the very beginning. I like to remind myself it's a little bit easier to do things in smaller states, but still, that was a success factor for them, and it has been one for us, which means we have great partners, initially with the hospitals, and now with clinics and safety net clinics and pharmacies and retail and independent. That's gone well, and we're going to continue bringing on new sites, not only to reach the community, but especially those vulnerable populations. So rollout here in Tennessee is going great. We just need more product.
Dr. Jungher, the same question, but put on your hat of being a local practicing physician and then also who is interacting with the state level that we just heard from. How is it going out here locally, and who all is involved in those efforts at the local level?
Sure. I would agree with the commissioner. As a city, we're on track with the state. About 7% of our city has received the first dose, so about 50,000 individuals. And if you include second doses, 75,000 people who live in Nashville have received dose. There are 75,000 doses that have been given to people who live in Nashville. The great thing about Nashville, though, is we have these amazing healthcare systems, right? And so partnerships with HCA, Ascension, Vanderbilt really helped get our number of dosage even higher. In fact, between first and second doses, over 100,000 dosage have been given in Nashville. So obviously some of those people are not in our county. They work probably in our healthcare systems and so forth. But as supply has become more and more available, what I'm really proud of is being able to work with our federally qualified health systems. So you have Neighborhood Health and Matthew Walker over the past couple of weeks have started receiving doses, in addition to about 10 others. Organizations such as Siloam Health, who I think does amazing work in Nashville, has started receiving some dosages, as well as I can't stop this conversation without saying what Metro Public Health has done. Just this week we rolled into the Music City Center, and we have just this weekend gave 3,000 doses to people who meet criteria. We have had events at Lentz. We have had, Meharry Medical College has had some amazing weekend events. And I'm sure there's some organization I'm leaving out, but our hope and our goal is, as more supply comes in, to partner with these amazing organizations here in Nashville that really, again, Nashville, we're with due respect to the commissioner who has to deal with 7 million, we have 700,000 people in the city that is very healthcare focused, right? And I think by us using those relationships, we'll continue to expand our reach further. But it is really has to do with supply. So that's been kind of what's been really exciting. But overall, it's going well. And I would say that whether the commissioner was here or not, our relationship with the state and getting supply has been really great. About a month ago, we were getting 5,000, and then our doses have gone up weekly to about 5,800, and then 7,000, and then we were supposed to get 7,800 this week, and through the commissioner and her staff, additional doses became available. So this week, Nashville has about 9,000 between both what Metro Public Health has and all the other organizations I spoke about. And that is superb to me. The commitment to continue to get dosage out as quickly as possible really is what's going to allow us to have success. And so our relationship with the state has been wonderful. And I think that the new federal administration, frankly, is going to continue to strengthen that.
Yeah, I think that's really important. As I talk to my former Senate colleagues around the country, and you do see in some states where the governor is fighting with his or her commissioner, and the commissioners are fighting with the local cities, and that's just not happening here in Tennessee. I think it's an important message that both of you send, that there is this seamless coordination between our government at the state level, the 95 counties, the health systems, and then the cities as well. Dr. Piercy, take us back a little bit, and you've explained that you had this existing infrastructure already, but talk to us a little bit about the prioritization plan for Tennessee and its relationship, because you have the CDC guidelines that are coming across, and you have some encouragement at the federal level, but then ultimately the prioritization process is yours. Talk to us a little bit about that.
Sure, and I think what you just said, the last statement you made, is the key to how we thought about this, and you can also see some differences between our states and others. So, CDC via the ACIP mechanism made recommendations on how to prioritize this. Because now, to be clear, I've said it. I know it's obvious, but I wish we had enough to give everybody at the outset, but we don't. And we knew that we wouldn't. So we knew that by necessity, we would have to prioritize. We also knew that when you start talking about prioritization, whether you want them to or not, people automatically internalize that as a statement of value or worth to a society. And there's absolutely no way that you will ever win that. And so what we did is we took ACIP recommendations, and like every part of this response, we said, all right, that's great federal guidance. How does it apply locally here in Tennessee? And if I had to say one success factor that the Trump administration had, that I think the Biden administration would be very keen to keep, and so far they have, is the flexibility for states. And so they've been very clear of these are ACIP recommendations, but you do what works for you locally here in Tennessee. Well, okay, that's a big responsibility. And so we certainly didn't want to keep that in our department. We wanted to bring in multiple stakeholders, mostly from outside of state government. And so we convened a pandemic vaccine stakeholder group in late August, early September. This was well before even ACIP started making their recommendations, and brought folks in from all different sorts of communities and constituencies. And so we've had this iterative process to where we took big chunks and then we're starting to make them into smaller chunks. And you'll see us revise our plan. We're going to continue doing that. I've always emphasized this is a draft plan and this is a working document. But what we found is we started with the data and what is affecting Tennesseans and what age groups are affected, what industries are affected. And we took a very risk-based approach. Not only is that the smartest way to do it from a scientific standpoint, in our view, but it also at least attempts to alleviate some of these concerns of, well, why do you think this group is more important than this other group? It's all about risk. And we even divide risk into 3 buckets. Number 1, risk to the healthcare infrastructure, because if you don't have that highest level of acute care, if you're in a car accident, a walk-in clinic is not going to be able to do anything for you. And likewise, if you get COVID and you need hospitalization or ICU, you have to preserve that highest level of infrastructure. So that's why we, as well as most everybody else in the globe, gave their healthcare workers doses first. But then when you start looking at it, who is at most risk for morbidity and mortality or hospitalization and death? And that's our elderly. So that was our number 2 bucket of risk, is risk to individual health outcomes. And then the 3rd bucket of risk is risk to society and economy. But there's a second part of those that are at high risk of exposure. So there are some very crucial and critical infrastructure that really don't have a high risk of exposure. And so you have to meet both of those criteria. And so we faced our plan like that, but we're always looking at it. We had another stakeholder meeting yesterday and just always iterating that process.
Yeah, let's pick up on that a little bit in the chat room, and we're going to open to Q&A questions. But in the chat room, this whole issue of diversity has come up in vulnerable populations. And this morning, Dr. Hildreth from Meharry, CEO and President of Meharry, and I spent about an hour and a half discussing vulnerable populations and the true success to date, but the real challenge that is. Dr. Jehangir, talk a little bit about vulnerable populations having access to the vaccine, our success to date, any plans or specific plans, and then a little bit about the overall disparities, vaccine hesitancy as well.
Sure, thank you. Listen, I usually sleep pretty well, but this is one issue that I do lose sleep over, right? The issue of disparity, equity, especially when it comes to vaccine distribution. I think one of the, there's a few things I want to kind of just put out there. Well, first of all, people need to really think about the data that's currently being put out there by those that claim that there's the disparity is we're way out the water, right? Up until a few weeks ago, the only people getting vaccines were predominantly people getting vaccines were those that were healthcare workers. Healthcare workers tend to be predominantly young white females. So if you look at the demographics of a vaccine in our state and our city specifically, you're going to see it skewed that way. So I think it is fair to now look at those 75 and over, because that's really the first group of the general population that should have equitable access to vaccine. Now, with that background, I will say we need to do better. So I'll tell you, as a city right now, 41% of those individuals 75 and over have received a vaccine in Nashville. Of those who are white, 34.5% of white individuals 75 and over have received vaccines, and only 19.1% of African American individuals over 75 have received a vaccine, right? And so I think that right there is clearly there's a discrepancy. And that's something that we at Metro Public Health and the mayor's office really want to focus on. So how do we go about focusing on that? Well, now that vaccines are becoming more available, I think first of all, you partner with people who that have the trust and access in the community, right? And we started working with Meharry Medical College. I've been to several of their vaccination events, and they have access within the community of and the trust of a lot of African Americans. So there's a lot of African Americans coming to those events. Partnering with FQHCs that have access to more minorities. Partnering now as more and more supplies come. Partnering with churches and community organizations our immigrant population. Let's not forget Nashville is about 12% foreign born, I being one of them, frankly. And I think, you know, we are currently in the process of developing those channels. There are some council members that I'm really appreciate that have been partnering with us very actively, who know their neighborhoods, who know the needs, and we're devising those plans that as more and more vaccine comes in, we get out there. But I guess my point is we need to look at the data consistently, but we also need to be honest with the data that we're assessing as we go through this. Now, it comes to the issue of hesitancy. Of course, it's a really, really big concern, especially in the communities we've just talked about. And we can dive into that a little bit more whenever that time comes. But thanks.
Good. No, I think the fact that you started exactly what you said with data shows the importance of being able to look at that data. When you said, you know, the white Caucasian data versus the people of color, and it causes all of us to think, all of us, what can we do to better improve that issue of vulnerable populations, equity, access? How do we reach? And so we'll just come back to that in a little bit if we have time, but it's fascinating, the response that you're taking both locally and across the state. You know, people listening to us are saying, this is really interesting, and I love the overall picture, but you know, I'll flip this to the commissioner. What they really want is just to get that vaccine in their arm and get that first shot and then get that second shot and then have that sort of sense of relief. Not that you stop wearing a mask or socially distancing, but just that you have your body working for you. So let's come back to the practical things, scheduling appointments, actually getting the vaccine in their arms. Commissioner, do we have a good system set up for people scheduling appointments?
Senator, the short answer is we're getting there. I like to remind people of the context, and I sort of say it tongue in cheek because I understand it, but I do want to remember, I do want folks to remember the context. We've been fighting this pandemic for 10 or 11 months. We've only had vaccine for 6 weeks. We're getting it out as fast as we can. And I know everybody wants it right now, but that we always knew that this was going to be a process, that this is going to take several months. But there is just an overwhelming demand for it in almost every instance. So what we learned very early on, and I referenced it a few minutes ago, which is the old system of, hey, we're having this big event from 8 to 4 out at the fairgrounds, y'all just come on. That doesn't work for 2 reasons in this scenario. One is limited inventory. You don't have any idea how many hundreds or thousands of people are going to show up. And then you've heard the stories from all around the country and even in this state where people sit in their cars for 4 or 5, 6 hours at a time only to be turned away because the supply runs out. So that is one reason. And then the other reason is we do have these priority phases. And as much as I would like to say people are following the rules, there are a lot of people that try to slip in and try to, they'll have a 75-year-old in the car, but they want to be vaccinated as well, even though they might be much younger. And so in order to make sure that those priority populations get prioritized, truly prioritized, as well as making sure that our demand or our supply meets the demand and the inventory, we have had to go very quickly to an appointment system. And pretty much everybody in the nation is having that realization that we just can't have these mass drive-up events without any idea of who's coming. And so we had that realization pretty early on, maybe just 6 or 7 days into the community vaccination process. And so we had to stand up an infrastructure pretty quickly. And the short-term fix for that, at least for the state, was something called Sign Up Genius. Other people are using RedCap. And it's basically sort of putting your name on a waiting list and then somebody calling you for an appointment. It works okay. It's a temporary fix. It's working for us. I want to tell you what's in the works for up next. But what we also saw, and it's understandable, but it's a bit frustrating, is that people would sign up online and then they would sign up in multiple counties trying to see which one they could get to first. And then they would continue to call and call and call, thinking that if they could just talk to a human, then they could get bumped up in the line. So, that's been a frustrating part for everyone. I think that's in a better spot now, but I'm really excited that probably before the end of next week, certainly within the next 10 days or so, we are moving towards a full online scheduling platform. So it's not just a sign up where somebody calls you and makes an appointment, you actually schedule an appointment online. And so that will have some bumps as we get it rolled out, but it's a pretty large system that's been used in several other states. And so we feel pretty confident that that's going to make things a lot better. This is something that public health nurses are really frustrated by, because if you've ever met a public health nurse, he or she wants to give everybody a vaccine who wants one and wants to serve the customer. And so the ability to say, or having the ability to say, I'm sorry, we just don't have the supplies, really difficult. And so we have to stick with this appointment system to make sure we can match that up.
Dr. Jahanger, any comment on the actually getting it in your arm and the scheduling? You're seeing, both of you are still seeing patients every week. I think that's important for our listeners to know that both of you are in official capacities, but you're both seeing people during the week and therefore have this first person input, which I think is just absolutely critical and admirable to both of you. Dr. Jahanger, anything else about the scheduling? And then I want to ask you a question about partnerships.
Yeah, no, I think, you know, I echo a lot of what the commissioner said, but what I also say here in Nashville, if you've actually spoken to people who've actually gone through the process, it's a pretty good process, frankly. You don't wait long, you feel safe, you come in, you get what you need, you have people to speak with. And I'm proud of that. We've process engineered that really well, just like we process engineered our assessment sites when we first came out, in a way that now we've tested, you know, 400 something thousand people at our assessment sites, right? So I think it's really easy from to comment, oh, we need this faster, we need this. But look at how we're operationalizing things in our city, in our state, compared to the rest of the country. We think this through, and sure, it could be always could be better, but I'm really proud of actually what our public health team locally has done, as far as not only are we getting appointments, but one thing that was really important for me and Dr. Gilwright and the mayor is, if we had any extra dosage, we weren't going to sit on them. So we have instilled a waiting list that we go through, you know, daily. And probably people don't realize it's probably 200 people off our wait list a day at minimum are being taken off this, their 75 and over wait list that we just kind of do quietly, and we just call people and get them in. In addition, we have the standby list that's you know, a few doses a day that we call people very last minute, no matter who you are, just to get the vaccine in somebody's arm. So those are all very important things. And so sure, there could always be processes maybe better, but my gosh, I think what we have done locally and what the state is doing is pretty darn good compared to most of the country.
Yeah, and I think that is really important. And it's come out earlier in our conversation that we are at the top in terms of the distribution of the vaccine and getting it in people's arms. Not perfect. We're learning as we go. We're having discussions like this, but it's important to know that we are doing very, very well there. Always can do better. Dr. Jahanger, what about the partnerships? Let's go back to the supply side. A little bit earlier in the sort of getting it in your arm. Go back to the partnerships that are out there, whether it's to make the drug stay active over time. We've heard about that they decay over time, and that there's the freezing end of things, and that they actually are distributed to the people who will put it in your arm. What kind of partnerships have been out there?
Yeah, so I have to brag on Metro one more time. We started seeing when the clinical trials were going out that some of the vaccines that looked promising required super cold freezers. And so as a Metro government, we purchased several of those early in the process. And I think that's what's allowed us to, first of all, be able to get receive some more of vaccine than maybe perhaps is possible to others. Now, by us being able to have access to those vaccines, partnerships, as I mentioned before, with our for example, Meharry, our health systems. You know, we're working on, for example, our first responders in Nashville were vaccinated very quickly because of the operational ability of HCA and TriStar. Right? They offered their willingness to open up their facilities and their operations to our first responders. Metro provided the vaccines, and we followed the chain of custody. I think a lot of people don't realize there's actually if the vaccine is allocated to us by the commissioner, it's our responsibility. We can't just give it to someone and not follow them. So we actually have a staff member who sits there with the vaccine, but the operational capacity of HCA, as we're looking at vaccinating a lot of teachers, we're looking to partner with some of our big health systems to do that in a quick, efficient manner. But beyond that, it goes back to kind of what we hit on earlier. It is those people who can't access those health systems, right? The people who, for whether it's transportation purposes or trust and who they're getting their healthcare from, we need to continue the partnerships that we've just started. And those of my colleagues who are on the call who are some of these great partners, I think Brian Hill, I think it's wrote a comment. So Neighborhood Health, for instance, great partner to help us get into some neighborhoods that we may not be able to get into. And I think as we get more vaccines, those partnerships are going to be very critical. Meharry Medical College has been a great partner to us from the whole get-go. And then beyond that, as we start looking, this morning I received a text from businesses in town that have capabilities both in space as well as people who can provide the vaccinations. And those are innovative partnerships that people may not be thinking about right now, but we're thinking through it. Again, the beauty of being in a city that has a lot of healthcare and a lot of space, a lot of people that can do this that may have not be your traditional people you think through.
Commissioner, so right now people are listening to us. They need to go to a website. What is that website, A, and to sort of see what class you're on? And then B, what about if you're 75 and you live in a rural Tennessee and don't have access to a computer or internet? What do you do?
Sure, those are great questions and things that have been top of mind for us. So the best one single source of information on all things COVID is covid19.tn.gov. Again, covid19.tn.gov. And that has Vaccine Finder on there. It is by county right now where you can sign up. As we get additional data, we'll be adding it to that site, but that is the best place to go right at the outset. That also has a link to our plan. Saw a question pop up about the stakeholder group. The stakeholder group is listed in that plan. But there are, to your point, Senator, there are people who don't have internet access or are not, they might have internet access, but aren't computer savvy. And so we recognize that and certainly don't want to create any barriers. I'll pause here and remind you that if you didn't see it, we have been touted nationally on multiple occasions, including by both former CDC Director Redfield as well as Vice President Pence, for having one of the most equitable plans in the entire nation out of all 64 states and territories. So making sure that our vulnerable population, including those that don't have internet access, still can get appointments. There is a telephone number for every single clinic, and they can take appointments that way as well or sign up for appointments. Now, as you might imagine, the phone lines get pretty busy. That has slacked off some since we've put the online sign up, and so you can get through on the phone that way. And we've also engaged senior centers, churches, other community agencies to help their vulnerable populations get signed up. And so either folks are doing that for their friends and neighbors, or those folks can call us and we can put them in that online scheduling. And so those are the ways people access it, but in no shape, form, or fashion do we want people to not have access just because they don't have internet.
Good. No, thank you. And we'll put that website up, if you didn't write it down, up on the chat room now so people can refer back to that. Commissioner, surrounding states, and some states are at 65 years of age. We were at 75 years of age. You can bring us up to date where we are today. How are you making those decisions coming in? And I understand the general classification, but who gets into 1A and 1B? Don't go into it in detail, but who's making all these decisions? Where are we today? And why are some states at 65 and some states are at 75?
Sure. Yeah, that's a great question. As far as our employer or industry facing, that was done by the pandemic stakeholder group. So that structure, that infrastructure is set. But as far as how quickly we move through the phases, that is a constant reevaluation. It depends on supply. That's almost the only consideration, but also on uptake. We have seen reduced uptake in our rural counties. That means they can move through the phases more quickly. You know, what we do not do here, and I think you've seen some pretty major examples nationally where this did not work, is to say, we're going to entirely finish this one phase before we move to the next one. We're not willing to go that slowly. So we want to keep moving the needle forward and expanding eligibility, but also keeping in mind for supply. So what you mentioned is that earlier this week, we went from 75 plus down to 70 plus, but there are many states nationally that have gone down to 65 plus. For us, it was a math equation on 2 counts. One primarily is based on risk. So I told you earlier that we're looking at Tennessee data and who in Tennessee is in the hospital and who is dying. We have looked at that at 5-year increments, and it was actually pretty surprising to me that, at least in my mind, I kind of thought everybody 65 and older was in the same high risk bucket, and then there was a big drop off. What we saw is there is a significant difference even in 5-year increments. And compared to 65 to 69-year-olds, 70 to 74-year-olds have a 40% higher risk of hospitalization and a 70% higher risk of death in just a 5-year increment. So when you look at, okay, how many Tennesseans are 70 to 74? Well, there's about 300,000 of them. We're getting about just north of 90,000 doses a week right now. When you do that math, it's going to take most of the months to get through that age category. And I talk to a lot of my counterparts across the nation pretty much on a daily basis. And the ones that have gone down to 65 really regret that because the supply can't keep up. And so what is happening, in fact, my counterpart in Texas told me on Monday, they're actually going from 65 back to 75 because it's been so chaotic. And the thing other than risk is that when you look at a mobile, tech-savvy 65-year-old who is at significantly reduced risk, I don't want that person competing for a vaccine with an 84-year-old who is very likely to be hospitalized or to die.
You know, again, your use of data. If people say, well, science is changing and, you know, recommendations are made in one way than a different way. And then in some ways that's true if we look back at the history of masks and how they've been used. But the important thing as we learn, as we collect data, for example, your difference between these sort of 60 to 65, 65 to 70, 70 to 75.
The virus. And so we're
that data
committed to moving.
We learn. Let's shift and appreciate people sending in their questions and answers, and we're incorporating that in our discussions, and we'll run through some of the other questions here shortly. One thing that people keep mentioning is classrooms and classrooms reopening and schools reopening, and that's something that many people listening to us right now are right in the middle of. Dr. Jehangir, why don't you talk a little bit about education and how is the vaccination rollout impacting the school reopening plans and how they're using data, and then I'll turn to Dr. Piercy also, because a lot of that is set at the policy level at the state.
Yeah, and I think that's right, Senator. For me, as in my capacity of Metro Public Health, as well as the COVID task force, I mean, I follow what the commissioner's recommendations are regarding Group 1B, and for us, it's really important to get to 1B as quickly as possible. And in fact, just this morning, last night, I've had multiple discussions to how we can get teachers vaccinated, again, as I mentioned earlier, through some of these partnerships we have with health systems, using supplies of vaccines. But to me, I've never, at least personally, I've never tied reopening schools to getting teachers vaccinated. I've been on the same mission of trying to get into our 1B group as quickly as possible. 3 weeks ago, I was on that mission, as I was last night, and Metro Public Schools obviously announced that they were rolling in, I think, phased in the next week or two. But there's other schools in Nashville that have been open for this time frame. And so I think for me, I want to just make the conversation, everyone just, again, I know when people think about this, you're like, oh yeah, of course. But there are a lot of schools in this city that we have. The Metro Public Schools obviously the largest, but in my capacity, I have to think about how do I vaccinate not only public schools, but parochial schools and independent schools and charter schools and daycares. And when you look at the math there, in metro schools still takes a big chunk, but there is still a good 5-digit number of people who fit the other criteria that are equally as important to get vaccinated. So from my standpoint, Dr. Gilwright and I and others have been working on operationalizing getting all those people vaccinated in a way that is efficient, that is equitable, and it is fair across the entire process. So our hope is to try to do this within this month. I know the commissioner said March. I think March would be, we would definitely will do it by March, but our hope and our desire, especially now that a large group of our schools are going back with Metro Public Schools, of course I want to try to do that sooner. And we're, I think, close to coming up with a plan. But again, it's a supply dependent thing. And I'm very happy, frankly, that the Biden administration has helped get supplies higher, and that the commissioners and the state are giving those supplies out as quickly as they get them. And so I feel optimistic we can do it within this month.
Commissioner, I want to turn to you, but before doing that, Dr. Jahunger, right now, the teachers are in this 1B classification. We've not reached 1B in the state. If you, sort of as the authority here in the metropolitan region in Nashville, basically said, we want to give it to teachers, can you override that 1A, 1B classification and institute it? Or legally, do you defer to the commissioner at the state level because that's what we've decided at the state level?
Privately and publicly, I'll tell you, I of course defer to the commissioner in the state. But with that said, Senator, I think this is the thing. The state has not put formal guardrails per se as to when we can roll the 1B, right? So 1A1 and 1A2 have been healthcare workers. Nashville has a lot more healthcare workers than probably anywhere else. And so we've been getting through those people. And people often think, well, the hospital system have been giving vaccines. Well, there are a lot of people who don't work in hospital systems that we've been getting through. Plus, developmentally delayed individuals and a few other people who fit into 1A and 1B. There's a concurrent 75 age range as well, right? And again, Nashville probably has more 75-year-olds than a lot of places in the city. And so we've been trying to, or state, excuse me. So we've been trying to fill that gap. So now for us, it becomes a policy decision of at what point do you perhaps have to give some resources that would be allocated to group 1A and those 75 and over, not maybe roll into 70 and older and shift into 1B, and then at what speed can you go into 1B? So it really, that part of it really does come in operations and policy decision based on our supply. And so those are the intricacies that we're trying to navigate within the rules, of course, that the state has set.
And Commissioner, just to kind of fill out this whole discussion of vaccination rollout, schools reopening, how quickly we get to teachers, from your role, just to help us all understand a little bit more where the policy comes from and where it's moving with regard to education.
Sure. So I'll be the first to acknowledge that Dr. Jahunger pushes the envelope with me all the time, asking to move forward faster. And I appreciate that because he is a great advocate for his city and his population. And so that's something that we always want to do at the state is keep pushing forward and making sure that we're making the best decisions and the most timely decisions. As it pertains to the 1B population, we actually already have about 40% of counties statewide that are in that. Remember earlier when I said the rural counties, because of reduced uptake, can accelerate through phases a little more quickly. That is true both because the rural counties, some of these rural counties not only have reduced uptake, but because they have smaller populations. You flip the script and it's different, a little bit slower in metro areas or larger rural counties. But the key message here is that teacher vaccination is not a prerequisite to opening the schools. We have had 145 school districts statewide open in some form or fashion of in-person learning since the late summer. And both we have seen it locally as well as the CDC has recognized it, that schools are not a significant source of transmission. So we're excited that Director Battle has, or Superintendent Battle has announced a return to the classroom. We think that is so very important for kids, not only for their education, but also their health and welfare. And so we're encouraging all school districts to get back to in-person as quickly as possible. And concurrently, we're pushing towards teacher vaccination. Dr. Jahangir's right. We have committed to no later than March 1st and are looking to move that up sooner as supply allows.
How is the state organized? Do we have, how many public health departments are there in the state? And then are you working through them and then allow them to determine based on supply what classification to be in?
So we have health departments in all 95 counties. The state manages the 89 rurals, and then the 6 metros are, I like to sort of think of it like a joint venture, but they're primarily run by those local counties and the county mayors and boards of health. But we make these phasing decisions on, we try to do it on a statewide basis. And when kind of a preponderance of our counties are saying, hey, this one category is starting to slow down in demand, we're pushing towards the next one. That does mean that occasionally counties are in different phases, which can make it messy. But as I mentioned earlier, that's the right thing to do. We need to go ahead and push forward as quickly as possible, even if it's a little disparate from county to county. Now, what we've seen is not only do the health departments offer this, the key success factor here is all the partners. So we started out with hospital partners, and some of them are continuing that. Some have said, hey, we did our workforce and we're going to go back to our core business of being a hospital, but some are wanting to vaccinate in the community, which is great. Last week, we announced an additional 100 access points. About 65 of those were independent pharmacies, and about 35 of them were safety net clinics or community health centers. And so we're going to continue doing that. With the federal pharmacy partnership that's slated to begin at the end of next week, they will be bringing on about an additional 100 Walmart locations. So by the end of next week, 120 out of the 150 Walmarts in Tennessee will have vaccine, in addition to the independent pharmacies. And then we've got 1,800 providers already enrolled and in the onboarding process. And so those are everywhere from clinics to all different kinds of pharmacies and everything in between. And as soon as supply allows, we will start seeding those partnerships. That's what we want to do. We want to get away from health departments.
Well, no, that's really good. Let's continue a little bit with that. Why Walmart and why not CVS or Walgreens? Who made that decision, and why was it Walmart versus the others? And then how long will it take before you think we'll see the vaccine in our local CVS or Walgreens?
Sure. So we looked at all 18 or 19 retail pharmacy chains throughout Tennessee. Walmart has the highest penetration in all across Tennessee, particularly in our rural areas. Really, the only other chain that had higher penetration was Dollar General, which they do not have pharmacies. And so we went with Walmart. But that's just initially. The rest of the retail pharmacies, CVS, Walgreens, Rite Aid, Publix, Kroger, are likely to begin seeing vaccine perhaps as early as late March or early April. But those are definitely on the list, as are many clinics and other medical providers. So health departments will always have it, but the more providers, the more access for Tennesseans.
Now that's interesting. I'm going through different questions. So again, I appreciate everybody writing in with their questions. On the National Guard, we've heard a lot about National Guard. States are using their National Guard in different ways. How have we in Tennessee used National Guard? B, how many National Guard have been involved? And then how different is it from the way other states have used their National Guard?
Yeah, so we've used National Guard since the very beginning. I think we brought them on orders maybe the 3rd week of March, but we've always used them a little differently than other states, and we will continue to do that with vaccine. A lot of that is driven by our very wide and sparse geography, and we have a very large rural as opposed to a compressed urban population. So we have used them in much more of a decentralized fashion instead of these large sites. You know, initially there were large testing sites. Now some people are using Guard for large vaccination sites. We have divided them out into smaller teams of 3 to 5 to go to rural counties, obviously much more, 20, 30 plus at our larger sites. And they're supplementing health department staff to give those vaccines. We've currently got about 100 guardsmen on orders and have made a request to FEMA and the National Guard Bureau to bring about a 4x multiple of that on orders and start to deploy those across the state. We've got, and you may have heard me say this before, we've got the capacity within our current infrastructure to do up to a 5x multiple of what we've got right now. And so in order to be able to do that, and then beyond that, we're bringing more Guard in. The other federal resource that we're using is, as of yesterday, 52 FEMA personnel came on board, 26 in Shelby County, 26 in Davidson County, to help with a lot of the logistical needs, parking, traffic flow, administrative, clerical support. And so we've got the manpower, we just don't quite have the supply that we need. The good news is we've got capacity.
Dr. Jehangir, there's a question here about making people more comfortable, vaccine hesitancy, but how are we making them more comfortable and assuring them that the vaccine is indeed safe and that it is fundamental, that it's critical to the health of themselves, the health of family members, the health of their communities more broadly?
Gosh, I wish I could answer that question with 100% certainty, right? And go on a national tour of it, because I think that is the crux of all of this once you have the supply chain figured out. I'll tell you, locally, we believe that the best way to do that is to get people who are trusted and have them be the messengers, right? I know that, watching me get a vaccine in isolation isn't going to save the world, right? So how do you, I think a lot of the hesitancy too is frankly, is warranted. And so taking the time to talk to people, educating people, calming their fears. I know personally, I'm in a big healthcare system, and I even here will have to talk to some of my colleagues about why not to have that hesitancy. And so I think a lot of it just comes down to education, finding trusted people. And again, these partnerships we've talked about are going to be critical for that. I know there are large organizations such as the Ad Council that is focusing on bigger things. I know the state of Tennessee is working on things. So it really is, there's not a one size fit all answer here, Senator. And I also think it is something that really is going to take a lot of diligence and hard work. Otherwise, I think you're right. There's going to be hesitancy, and there's going to be a population percentage that is larger than I'd like to see not get this vaccine.
We're just about out of time, unfortunately. I want to move to sort of a crystal ball question to both of you, looking ahead sort of over the next 30 days and then maybe longer than that. But before doing so, are vaccines, they're free now? People are listening and say, are they going to cost me something? Are they free now, and will they be free 6 months from now?
They are 100% free to the patient. It is allowable for anyone to bill third-party payers for an administration fee, but there is a federal regulation that you may not charge the public, any American, for that, or anybody in America for that vaccine. And so while health systems may choose, or pharmacies may choose to bill insurance for the administration, the patient will never see that, including those uninsured. There is a federal provision for that, always free to the patient.
Well, let's turn to the crystal ball look, and it's always dangerous because these sorts of presentations, we will have this available for people who have not been able to tune in today. And I do appreciate everybody being with us today. But it's always dangerous when you have it out there because people will come back and listen to it. But how do you see, and Alex, I'll turn to you first, but the next 30 days, you've been really on the forefront and have done an unbelievable job in terms of the communication aspects, being a physician and being able to speak directly to people on behalf of Metro, on behalf of being a physician, and on behalf of really the consumer in so many ways. So this is a tough one, but how do you think over the next 30 days we're going to be going?
Yeah, so I think 30 days we'll have more of a foundation of how this thing's going to roll out permanently. So I think 30 days from now, I envision that we will have, we've rolled into 1B. We've rolled definitely in Nashville to 70 plus. We have gotten a double-digit percentage of our county, at least with their first doses, and we have assurance and stability from the state and the federal government that vaccine supply will keep coming. And with that, we will then solidify these partnerships that we've hinted at throughout this talk, and really come up with a plan that then will be self-sustaining moving forward for many, many more months. So I think everyone on this call probably knows this thing is not going to be done in isolation in May, right? By June and July, we may be at a good place, but vaccines are still going to be distributed then, and we need to have a self-sustaining system that allows for that. And I think the next month is where we're going to solidify that locally.
And on the vulnerable populations, are you fairly optimistic we're going to do well or better over the next 30 days?
I hope so, right? I'm not going to sit here and make bold statements of it really is something that I do think a lot about, and it's not going to be me in isolation who's going to solve this problem. So I'm going to lean on people who really do this on a day-to-day basis. There's a lot of good people who do that, and it's not going to go without effort.
And the attention. And I think as long as we keep talking about it, there's smart people out there and partnerships out there, and people are focusing on it and appreciate it. And then talking to Dr. Hildreth at Meharry today, and he's basically saying that just as more people get vaccinated, the vaccine hesitancy, it seems to go more to the backdrop. There's more comfort level. Commissioner, looking ahead, what are your thoughts?
Yeah, so I agree with Dr. Jahangir's crystal ball on 30 days. When I look a little bit further out, if you look maybe 90 days out, I think we will have a third and or potentially fourth vaccine in rotation. That's really going to accelerate efforts. And perhaps it's a pipe dream, but I would like to think by mid to late summer that a supply is going to even exceed demand. I think it's going to be really ramped up over the next few months. And then ultimately, the health departments will continue to have a role in vaccination as we have throughout our existence. But this will become much more medicalized. It will just be another shot that you get at your doctor's office. We don't know yet if it's going to be a once and done, or if you're going to have it every year. That still remains to be seen. But eventually, this is going to not be a government thing. This is going to be a medical and healthcare infrastructure thing, and that's the way it should be.
Just listening over the last hour to both of you illustrates to me the importance of our infrastructure, our public health infrastructure. And for so long in this country, and it's gotten reflected in Washington, public health has almost been a stepchild to a lot of the acute care that we've given. And I think now people realize, if you really stand back, there is nothing more important if you're talking health and well-being than support of our healthcare. Public health infrastructure is brought to the forefront. And I think both of you represent that. You're on the front lines in terms of communication, in terms of substance, in terms of interpretation of the science for us. I want to thank both of you for being with us today. We are all indebted and proud of your public service and for what you do for patients and individuals and families every day. We appreciate you and your teams behind you and all you're doing to make sure that our families, as individuals, stay safe and healthy. Molly, let me turn it back to you.
Thank you, Senator. And thank you, Commissioner Piercy and Dr. Jahangir, for your comments today. They were helpful, and we will all go away and hopefully get our vaccine soon. I want to thank the sponsor, Blue Cross Blue Shield, for making this event possible today. And thanks to the Metro Public Health Department for sponsoring this event with us. And thank you for your time today. Be well.